Good evening, ladies and gentlemen. My name is Anikwe Onwanye, the president of the Association of Black Cardiologists. I want to welcome you all to the Table Talk series. And I just want to take this opportunity also to thank the co-chairs for the Maternal and Children Committee, Drs. Keocha Bond and Dr. Annette Ansong, for inviting me to give the opening remarks. And also, I want to acknowledge the hard work and the fantastic work of the co-chairs, the committee members, and the staff in developing and delivery of the Table Talk series that have been well received. Today's topic, which is for the 5th edition of the Table Talk series, is focused on the pulse of LGBTQ plus health and spectrum of care. The LGBTQ community is part of the historically marginalized groups or communities, which are traditionally defined as those who experience discrimination or exclusion across economic, political, social, ideologic, and cultural dimensions, such as, for example, people of color, lower socioeconomic status, persons living in rural areas, people with disabilities, and women. Unfortunately, there is limited data in the LGBTQ community because of discrimination and non-inclusion in clinical trials, leading to absence of data that can inform the quality of care and the standard of care. The LGBTQs are exposed to a distinct and unique health risk, which must be considered in developing culturally tailored and health promotion programs. From the limited available data, such as the behavioral risk factor surveillance system from the CDC, such data show a higher prevalence of, for example, cardiovascular risk factors such as tobacco use, hypertension, and diabetes in LGBTQ compared to heterosexual counterparts. A major driver of health disparity is stress. Multi-level stress operating at intrapersonal, interpersonal, and structural levels combined with unhealthy coping behavior results in abnormal physiologic and psychologic outcomes, such as, for example, the increased cardiovascular risk factors, mental disorders, and other conditions. At this juncture, it is relevant to reiterate the mission of the ABC, which is to promote the prevention and treatment of cardiovascular disease, including stroke in Black people and other minorities, and to achieve health equity for all through the elimination of disparities. With this mission, the ABC is saving the hearts and minds of a diverse America. It is my hope that this event will help to highlight the LGBTQ community's health concerns, particularly the cardiovascular health concerns, and provide some pragmatic tips for our clinical practice. Once again, thanks to the planning committee for putting this well thought out seminar together, and I wish you all a happy deliberation. Thank you.
Thank you, Dr. Onwanye. Good evening, everyone. I am Dr. Annette Ansong, a pediatric cardiologist in Washington, D.C. We started the Table Talk series to highlight the spectrum of cardiovascular disease from childhood to women in their reproductive years to the postmenopausal woman. We also sought to highlight the disparities that can occur to women and children seeking cardiovascular care. It is our hope that you'll find the series educational, engaging, and empowering. The Pulse of LGBTQ plus health and the spectrum of care, tonight's event, seeks to spotlight those disparities and inequities in care that can occur in one of our most underserved populations, the LGBTQ plus community, and also to offer tools to correct those imbalances. Without further ado, I'll now turn it over to my co-chair, Dr. Rachel Bond, System Director of Women's Heart Health at Dignity Health in Arizona. Dr. Bond.
Thank you, Dr. Ansong, and thank you also, Dr. Onwanye, for that wonderful introduction. And thank you for those who are joining us today, as well as those that are joining in particular to support the Association of Black Cardiologists. Our objective of this table talk is really geared to focus on the pulse of the LGBTQ plus community and to learn about several cardiometabolic risk factors that disproportionately impact this community, but most importantly, address preventive measures that start with us as healthcare professionals providing allyship and support. All areas of this country and world should be providing this inclusive care and support, especially when it comes to something as intimate as heart health. With that, I'm delighted to introduce our panelists and our wonderful moderators, who are two phenomenal women in medicine who will be the future of cardiology. To start off, we are just blessed to have Dr. Keocha Bond. Dr. Bond is a behavioral scientist and sexual health educator. She centered her work on the complex intersections of race, sexuality, social justice, and health equity among individuals of marginalized genders. She's an assistant medical professor at the Department of Community Health and Social Medicine for City University of New York School of Medicine, my alma mater, and the director of the Love Project Lab, which uses innovative science and community engaged techniques to develop research and intervention methods focused on reducing sexuality-related health inequities and enhancing equity. And last but most importantly, she's my amazing cousin. We're also wonderfully blessed to have Miss Lisa Cunningham. Lisa Cunningham is an Atlanta native whose career professionally spans over 25 years within the film, television, and web. She's directed and produced hundreds of projects for clients tendering from Fortune 500 companies to non-for-profits. Lisa currently serves as the Director of Digital Communications for the Black Women's Health Imperative, with highlights directing campaigns featuring Sierra, as well as Mary J. Blige for cervical as well as breast health. As an influencer, Lisa serves on the LGBTQ advisory board of the former Atlanta Mayor Keisha Lance Bottoms and currently serves on Mayor Andre Dickens' transition team. A sought-after motivational speaker and philanthropist, Lisa thrives in service to community and impact work. We're also additionally welcoming Dr. Melvin Eccles. Dr. Eccles is an associate professor of cardiology with the Department of Medicine and the Cardiovascular Disease Fellowship Program Director for Morehouse School of Medicine. Dr. Eccles' primary area of focus is preventive heart failure cardiology. He's graduated from Morehouse School of Medicine in 2002 and completed internal medicine and cardiovascular disease residency as well as fellowship training at Duke University in 2010. Dr. Eccles provides care to a diverse population of cardiac patients and focused a lot of his research efforts on heart failure, quality improvement, and healthcare disparities. He is a member of the Association of Black Cardiologists and serves on the Heart Failure Collaboratory, the editorial board of the Journal of Cardiac Failure, including Heart Failure Society of America, as well as the American College of Cardiology, Diversity and Inclusion, LGBTQ+ subcommittee. We're also joined by Dr. David Levine. Dr. Levine has been a faculty at Morehouse School of Medicine in Atlanta, Georgia since 1995. Current activities in the Department of Pediatrics includes coordinations as the coordinator of pediatric medical school education activities and general pediatric service with underserviced children and families at Morehouse Healthcare. Dr. Levine was appointed to and served on the National Committee on Adolescents of the American Academy of Pediatrics, and is also active in the Georgia chapter of the American Academy of Pediatrics, currently serving as the chair of the Committee on Adolescent Health. Areas of special expertise for Dr. Levine include working with adolescent men, as well as the LGBTQ youth. He was the lead author of the 2013 policy statement and technical report on office care for the LGBTQ youth from the American Academy of Pediatrics. We are also wonderfully to have our two moderators, one being Erica Webb. Dr. Erica Webb is an internal medicine resident completing her first year at Bridgeport Hospital in Connecticut. She first obtained her Bachelor of Science in Community Health with additional studies in healthcare management before obtaining a Master's of Public Health at Creighton University. Subsequently, she completed her medical degree in the Caribbean at Saba University School of Medicine. There, she developed an interest in women's health with an interest in the prevention of cardiovascular disease. She's interested in pursuing a cardiology fellowship, hoping to establish a career in cardio-obstetrics as well as preventive cardiology. And last but not least, Dr. Kendra Ivey. Dr. Ivey is a rising third-year internal medicine resident at Morehouse School of Medicine. Kendra's from Houston, Texas, and is a proud HBCU alumni of Prairie View A&M University and Morehouse School of Medicine. During her time at Prairie View A&M University, Kendra was a member of the Honors Program, Undergraduate Medical Academy, Alpha Kappa Alpha sorority, and Model United Nations. As a medical student, Kendra served as president of the Morehouse School of Medicine Student Alumni Association and student co-founder of both the Cardiology Interest Group as well as the American College of Lifestyle Medicine Interest Group, where she focused on organizing student and community-centered events to improve knowledge gaps in nutrition education. As a Black female member of the LGBTQ+ community, she is passionate about destigmatizing and achievements of health equity among the LGBTQ+ communities and people of color. And with that, I'm going to hand it over to Dr. Ivey to get us started.
Thank you so much, Dr. Bond. I am thrilled to be here tonight and ready to get started. So, to begin, a statistic that many of you may or may not be aware of is that according to the CDC, cardiovascular disease is the #1 cause of death in men and women in the US, accounting for nearly 1 in 4 deaths every year, and is the reason why we are all putting on this table talk tonight. In general, cardiovascular diseases includes an entire family of conditions of the heart and blood vessels, most commonly due to clogged arteries of the heart, arms, legs, brain, and more. When the heart vessels are blocked, it can lead to severe pain called angina, or worse, a heart attack. Black women tend to have far higher rates of heart disease than their counterparts. They tend to also die at younger ages than their white counterparts. Similarly, nearly 2 in every 3 Black men have some form of heart disease and an even higher rate of death, especially at a younger age than their white counterparts. With the percentage of US adults identifying as lesbian, gay, bisexual, transgender, queer, and more increasing to a new high of 7.1% of the general population, which has even doubled since 2012. The LGBTQ community are arguably one of the largest underserved populations in this country. Because of the lack of research and data, the ability to characterize the rates and types of cardiovascular disease is limited. Much of this data that we have is based on self-reporting. So our talk today will take us on a walk in the shoes of Mr. Marcus Boyd, a 44-year-old transgender Black male. Gender can refer to one's own internal sense of being a man or woman, or another stereotype that doesn't fit either category. Gender can also be expressed externally through clothing, behavior, body characteristics, and so on. The lack of public familiarity with this concept, along with its intersection with sexuality, is a leading barrier to many of the health issues at play for people of the LGBTQ+ community. As such, before we dive into Marcus's story, Dr. Keocha Bond, can you please walk us through the different terms and how we can best define Marcus's gender difference from his assigned sex at birth?
Definitely. Thank you for having me here to talk to you about this topic, because one of the most important areas is to actually understand the terminology that is associated with sexuality and gender identity. So, and it's always important for us to first understand that all people have a sexual orientation and a gender identity. And with that, understanding what your sexual orientation is a person's emotional and physical and sexual attraction to other people, an expression of that attraction. But gender is a little bit more complex, really because it involves several different factors, including like social and legal status and set of expectation from society about behaviors, characteristics, and thoughts. And so each culture has their own standards about the ways people should behave based on their gender. But instead of it being about body parts, it's more about how you are expected to act and because of your sex. And when I refer to sex, we're referring to what we call the assigned at birth biological sex, but that term doesn't fully capture the complex biological and chromosome variation that can occur. Having only two options, biological and male or biological female, might not describe what's going on inside a person's body. So instead of saying biological sex, some people use the phrase assigned male at birth or assigned female at birth. And this acknowledged that someone, often a doctor, is making the decision for someone else. And the assignment of a biological sex may or may not align with what's going on in a person's body and how they feel or how they identify. And that's where we come to gender identity. And this is an individual's language for their expression of self. And it is a place relatively in the culture's prevalent binary spectrum. So it goes beyond the whole male-female spectrum that we usually are accustomed to talking about. And gender expression is an individual's physical characteristics and behavior, and the presentation that is linked traditionally to masculinity, femininity, or androgyny in such as appearance, dress, mannerisms, speech patterns, roles, and social interactions. So with this, we know that there are two truths that we need to understand when it comes to gender identity. Sex assigned at birth and gender identity are different and independently complex constructs, as well as the fact that sex assigned at birth and gender identity don't always align. And so gender diversity is about us acknowledging and respecting that there are many ways to identify outside of the binary male and female. And we can continue. And now when we talk about what has been phrased like the alphabet soup, and this is considered to be a comprehensive collection of terms used by and about the LGBTQI plus community. The LGBTQ plus community is the umbrella term, and the more letters may be added in and some may not be used everywhere. This version of stands for lesbian, gay, bisexual, transgender, transsexual, queer, questioning, intersex, pansexual, two-spirit, asexual, and ally. And it really, the plus sign really signifies the inclusion of all other identities, and which may be part of or align themselves with the LGBTQI plus community. And it's important, again, for us to understand how people identify can change, and the terminology that we use today is going to vary. And it's also important to respect people's desire self-identification. Never assume another person's identity based on that person's appearance. It's always best to ask people how they identify, including what pronouns they prefer, and to respect their wishes. It's also important to recognize that while a person may use a term to describe themselves, they may not be able for someone else to do so. So when in doubt, you should ask. Let's continue.
Thank you so much, Dr. Bond. I know that these can be really confusing terms for people if you're unfamiliar with them, you don't normally use them. They certainly take practice to fully understand. I really appreciate that. So right now we're going to continue with Marcus's story to see why understanding these terms is so important. So let's meet Marcus Boyd again. Marcus is presenting to the primary care clinic today to establish care. Marcus recently attended an ABC Spirit of the Heart Community Health Fair 2 months ago, where he was cautioned that his blood pressure was elevated at 145/90, and his BMI of 32 placed him in an obese category. Upon this news, Marcus had several thoughts. One, how prior to his transition and during his last pregnancy, he was diagnosed with preeclampsia that led to premature delivery. How he lost his medical insurance 2 months after that delivery and had not seen a provider since. 3, how his mother, who was living with obesity, high blood pressure, and high cholesterol, subsequently died of a massive heart attack at the age of 51, and how his maternal grandmother was debilitated from a stroke at 67. 4, it was time to finally prioritize his health. So Marcus smokes roughly 1 pack of cigarettes per day since the age of 16, and about 2 to 4 beers a week, sometimes more, since recently being laid off from his job as a truck delivery driver. This has added an additional layer of stress, as he's found it difficult to find a stable job. So now he's been forced to perform random handyman tasks throughout his neighborhood as a way to best care for and provide for his family of his girlfriend and 2 children. So now we have a poll for the audience, one of several. Which one of these conditions are risk factors for heart disease for Marcus? A, smoking, obesity, high blood pressure, sporadic medical follow-up, chronic stress, family history, obstetric history, or all of the above. Give everyone a second to click your button. Choose wisely. Okay, what have we got? The answer is, okay, there we go. H, all of the above. So that's excellent. So if you didn't pick all of the above, I see where you were going. You were definitely correct with family history, but it was really everything. And we're going to get into talking about each and every one of these reasons and why they're all risk factors later on. Okay. Marcus's situation is unlike so many, where healthcare is often fragmented. Luckily, he was seen at a local Association of Black Cardiologists community health fair, where he did start to learn about his specific risk factors. So now we're going to get into those risk factors. This first question is going to be directed at Dr. Eccles. Dr. Eccles, how would you best define cardiovascular disease?
So thank you, Kendra. I think you hit it on the head initially when you previously defined cardiovascular disease. So technically any disease or condition that is involving the heart or the vessels thereof that actually relate to either structure or function. So there are many types of cardiovascular disease that can come from risk factors such as heart failure. You can have heart attacks or what we classify as myocardial infarctions, but heart attacks, and also issues with the circuitry of the heart. So you can have issues with arrhythmias as well. And then, as you also alluded to, blood clots. So blood clots can cause all kinds of problems, from electrical circuitry abnormalities to strokes. So, there are, traditionally, there have been risk factors that we think are, modifiable. And these are listed here, where we have high blood pressure, which, as you very well know, is extremely prevalent in the African-American community, as well as high cholesterol, diabetes, smoking, alcohol, obesity, and physical inactivity. And then you have the, what we consider non-modifiable risk factors, which can be age or gender or family history. So these are technically things that you can't change. And we probably shouldn't say gender, but we should probably say sex. These are things that you can't change. Next slide. So in terms of the non-traditional risk factors that I think are very important and actually becoming more sort of emphasized these days, are really centered around more sort of holistic sort of views of what stress is and what how stress sort of mediates a cardiovascular disease. And so, as you see here, racism, obviously in the last several years has become a very hot button topic for people in terms of how it induces stress and actually causes cardiovascular disease. But any really kind of psychosocial stress can do that. And that evolves from anything from homophobia or transphobia to the general stress of everyday life, stressful jobs, stressful situations trying to make ends meet. And this is where we come into the issues with social determinants of health. We also know that social determinants of health tend to oftentimes group in clusters of regions, and this can actually be defined as through zip code or regions in different places in the United States, as well as food deserts, where there are literally neighborhoods and populations and communities that just do not have access to proper healthy food. And I always make this comment about how it's, particularly in Atlanta, but I think in everywhere where you can go to one area and see a grocery store of the same brand, and then drive across town to see it in another wealthier neighborhood, and the choices and the access to the healthy options are completely different. It's dramatic. If you're in Atlanta or if you're in a large city, I implore you to try that out. Just go and see the differences for yourself. But then there are also, socioeconomic status issues that we talk about in terms of income as well as education, and these actually, you may not think this is definitely a risk factor, but it definitely is. And whether or not that is, sort of related to the stress of trying to make ends meet, or having the health literacy that you need to have. These are all very important non-traditional risk factors that I think are novel ways to intervene on cardiovascular disease.
Thanks, Dr. Eccles. So given all of these risk factors between traditional and non-traditional, can you kind of talk to and speak about how the community, through leaders or faith-based members, barbershops, beauty parlors, or health fairs even, will help to engage the health of marginalized groups of people? And specifically, what do you know that the ABC is doing to push this mission forward?
So, very good question. I will, say that you, Kendra, and I share some similarities, being that we both came from Morehouse School of Medicine, and we know very well that as medical students, they emphasize community engagement very early on. And so I think that, the community leaders like organizations such as Morehouse and ABC have done exactly that. Now, community engagement is not something that is a one-off and done. This takes years of focus, years of dedicated partnership, and in order to make sure that each person in this partnership, or each entity in this partnership, is getting the best that they can. And so sometimes that actually means going into the community and providing information or health fairs for faith-based organizations or barbershops and what have you. As you've alluded to in this very nice clinical vignette, ABC does quite a bit of that in terms of the community engagement that they provide for health fairs and patient-facing educational programs. So ABC is above and beyond doing its part in terms of making sure that we're getting out there and getting our message out to the community.
I completely agree. I will never forget my spending an entire semester focused on our community focused, community-based learning course. And I thought that was so special.
I think it's important. And I think it should be something that is mandatory for medical students. I remember myself some odd years ago feeling a little bit, nervous about getting into the community. What would they think? But to be quite honest with you, the community is welcoming and open for education, advice, partnership, insight, and it's not all about what we can teach them. It's about what we can learn from each other. So that's a valuable lesson, particularly on your pathway to becoming a doctor.
Yes. And so much about it is, the takeaway that I got was you listen to the community. You
Absolutely.
Give the community what they need, not what you think they need.
Exactly.
So to move on, Dr. Keocha Bond, I have a few questions for you. Are there any risk factors that Marcus has that are disproportionately higher in the LGBTQ plus community?
Yes, there are many risk factors that Marcus has that are similar to other members of the LGBTQ community. But like we spoke about before, I always like to get away from the idea of blaming the individual constantly. We need to understand that only 20% of our health outcomes are contributed to medical access, and the rest is the environment and social behaviors. And so with that in mind, I just wanted to frame this in the mindset that individuals from the LGBTQ community are experiencing these social stigmas and discriminatory treatment while they're in society and even in the medical healthcare setting. And so that's something to think about while we look at these numbers here. So like here first, we understand that with sexual minority women are nearly twice as likely to be obese, pre-diabetic, and engage in smoking tobacco, and are more likely to have higher risks of physical inactivity and stress. Next slide. And also similarly, gay men have nearly twice as higher rate of smoking tobacco and about 50% more than the general population when it comes to higher rates of additional substance use. And that includes alcohol and illicit drugs that are usually associated with higher risk rates of stress. And next slide. And when it comes to transgender people, they have higher rates of HIV infection, obesity, sedentary lifestyle, alcohol abuse, and smoking tobacco compared to the general population. And they make up about 1.2% of our general population. So in comparison, you can see the disparity when it comes to those different health outcomes. Next slide. And when it comes to psychiatric conditions, members of the LGBT population, this usually occur at a much higher prevalence with them when they have, many of them have higher rates of depression also. So again, it's important for us to understand this in the context of the environment that many people of the LGBTQ community are living in, and not just look at the health outcome alone by itself.
So Marcus is, given all of these that you just mentioned, Marcus clearly has several of these specific or uniquely higher risk factors, given the recently being laid off from work, also having this high, smoking history. And I think that his story is perfectly in line with what you just described. So thank you. Perhaps one of the most relevant parts of Marcus's history overall is his past obstetric history. So when we delve further into this, we realized Marcus has had 2 pregnancies in the past with a previous male partner, which were then both complicated by premature labor at 34 and 36 weeks gestation due to gestational hypertension and preeclampsia. So Dr. Rachel Bond, I have a question for you. How would you best define gestational hypertension and preeclampsia?
Yes, thank you, Dr. Ivey, for that question. And I think to kind of framework why we're even bringing up the obstetrics history is, as you very nicely mentioned, cardio-obstetrics, which is a sort of evolving field, is really trying to pave the way that what happens during our pregnancy can absolutely impact our future cardiovascular health. We know that in Marcus's case, he did experience preeclampsia. And how do we differentiate that from the definition of high blood pressure during pregnancy, which is the technical term gestational hypertension? So the way we best define that is by anyone who is either pregnant at the time, who had a normal blood pressure prior to 20 weeks gestation, now having an elevated blood pressure defined as a blood pressure above 140/90 after 20 weeks gestation. What separates the gestational hypertension from the preeclampsia is that preeclampsia, you have elevated blood pressure, but you also tend to have evidence of end organ defects. So protein in the urine, possibly elevations in your liver proteins, possibly headaches and visual changes, really demonstrating that the neurovascular system or the neurological system is compromised, and even presenting with pain in your chest or shortness of breath and swelling, uncontrollable swelling that's not going away, that's not necessarily in the legs, but also going up to the hands, the upper parts of your upper arms, as well as your face. So it's really important that for anyone who is currently pregnant, or even after their pregnancy, up to 6 weeks after pregnancy, you could have a risk factor for having both gestational hypertension as well as preeclampsia.
Very well stated. How or what risks do these conditions play in both the short and long-term health outcomes of our patients?
Yeah, so the reason these conditions are so important for us as clinicians to screen for, and for those in the community who may have experience to know, is because in that short-term period, it could absolutely impact your cardiovascular health. It can very commonly lead to a weakening of the heart muscle, something called peripartum cardiomyopathy. But we also know that long-term, it could increase your risk of actually transitioning to something called high blood pressure or hypertension, where you have kind of the normal essential hypertension. Those that have pregnancy-related complications, such as gestational hypertension or preeclampsia, are 4 times more likely to develop eventually hypertension. Cardiologist is key to preventing this possible outcome.
Dr. Bond, I think that last half just cut out.
So I will repeat that. So
Thank you.
As mentioned, these particular conditions, such as gestational hypertension and preeclampsia, they can predispose you to future cardiovascular risks. And this is why it's extraordinarily important that you have an established relationship with the obstetrician, a primary care clinician, and potentially a cardiologist, so we can look at.
And I think I understand exactly what you're saying, because I've had patients before who, and even as just a trainee, I've had patients where they've said, oh, well, I never had hypertension until I was pregnant. And now, I have it and I don't know why I can't get rid of it. But that's exactly what you're saying. And I've personally seen it firsthand. So thank you so much. Now I have my final question for you. And I think I already know the answer. I already know what you're going to say, but would follow-up have been suggested beyond those 60 days? Because we know that per Marcus's story, he lost his insurance after 60 days postpartum.
Yeah, and this comes into play because we know that 50% of pregnancies are Medicaid, and typically in the United States, Medicaid coverage ends after 60 days after the pregnancy. What we know is that these complications can occur even up to 1 year after one actually delivers. So as a result of that, it's extraordinarily important that we have continuous care, not fragmented care. So I'm really hopeful that with the American Rescue Plan Act that is currently giving the option for several states to extend their Medicaid coverage from 60 days to 365 days, that we will see improvements in these poor outcomes that we're seeing, because that's where we have the opportunity to establish with primary care clinicians, potentially cardiologists, and ensure these patients are plugged into our clinic to focus on all those preventive measures.
Thank you so much, Dr. Bond. So at this point, we will be continuing our story, or Marcus's story, with Dr. Erica Webb.
Thank you, Dr. Ivey. So let's go ahead and finish Marcus's story. So Marcus has been inconsistently taking testosterone purchased off the street for the past 2 years without supervision of a medical professional.
He's been experiencing what he considers to be heartburn for the past 6 months as well. And he's noticed worsening of his symptoms over the past several weeks when he goes for walks with his girlfriend. So I'm going to ask the audience, taking into consideration Marcus's history that Dr. Ivey talked to you about, what do you think may be causing his heartburn? Do you think it's A, gastric reflux, B, high blood pressure, C, coronary artery disease, or what we call blocked artery of the heart, stress or anxiety, or would you say E, all of the above? And while you guys go ahead and vote, I'm going to go ahead and ask a question to Dr. Eccles. So understanding Marcus's risk factors and presenting symptoms, what are you most concerned about as the culprit for the indigestion?
Come on, Dr. Webb, I'm a cardiologist, so you know what I'm going to say. But, also internal medicine, so let's be holistic about this and create a differential, okay? Marcus does have risk factors as well as some obesity, which obviously you definitely want to, sort of at least evaluate for these other things like gastric reflux, particularly with high blood pressure. As I've stated, high blood pressure is very prevalent in our community. And then when you add on top of the factors of obesity and other things that are going on, alcohol, smoking, it's very, likely that he may have some of this as well. Stress, anxiety, again, this is unfortunately, this is sort of the baseline for a lot of people in Marcus's situation. And it's outside of just being, race or ethnicity, but these are other factors that, many people that are not part of the LGBTQ community have to deal with. And so a baseline level of stress and anxiety most certainly can increase the risk for all of these risk factors. Now, obviously, I'm going to say I'm very concerned about a coronary artery blockage, primarily because of certain factors. So this chest discomfort that he is getting is actually related to exercise. It's actually kind of come all of a sudden. Marcus also has risk factors, as we've already stated, in terms of the things that he is doing that are modifiable, but then he also has non-modifiable risk factors as well, such as the family history. And when you see a family history of a mother, first degree relative, mother, female, with a heart attack before the age of 55, that's actually pretty significant. And so even though Marcus is 44, there are other things that he unfortunately is doing to his body that could progress that quite significantly. So my answer would be, I'm concerned mostly about C. But again, you could be concerned about all of them.
Okay, let's see what our audience said. Okay, all right. So most people did say all of the above. The correct answer would be, as Dr. Eccles said, coronary artery disease, the blocked artery. So as Dr. Eccles had breaking it down, based on when he has these symptoms, when he goes on walks and he's exerting himself, we're most concerned that there's some coronary artery disease as well, especially taking into consideration his history.
And now, Dr. Webb, I'm sorry, I do really, because it looks like nobody chose C. Was that right?
Can it go back?
I think it was 0.
Yeah.
And again, this is an opportunity. This is an incredible learning opportunity here. Okay. Because this is one of the reasons why women, and other sort of non-traditional groups actually suffer worse outcomes from acute coronary disease. And that is because these symptoms go unnoticed because they're either younger or they don't have as much access to medicine. So this is an incredible teaching opportunity for the people on this webinar. You have to be concerned about the most deadly issue for us all, white, Black, race indifferent, cardiovascular disease. So I'm glad everyone thought all, but it's interesting that no one picked C, but you definitely have to be concerned about that.
Absolutely. And that goes into my next question. Let me go here, back to the slides. So can you please help us best understand
as you talked about the typical and more accompanying symptoms for heart disease?
So honestly, I always, when I'm talking to patients about typical heart disease or typical chest pain that may be related to heart disease, I always refer to the Fred Sanford picture. And some people may not know what I mean, but basically there was this character on a comedy show years ago who would grab his chest and look up to the sky and say he's coming to his wife, chest pain. It's exactly, Kendra, Elizabeth. I'm coming to meet you. But I want to make sure that people understand typical symptoms are not typical for everybody. Again, I keep going back to the issue with women. Women can have symptoms that people don't, acknowledge as typical. And those, because they're not detected early, that's women have worse outcomes for acute coronary syndrome. And so, I would say chest pain that, if you ask me traditionally typical chest pain that's in the what we call left side or substernal of the chest, sort of in the middle of the heart, chest pain that's a squeezing sort of pressure type pain, not sharp as stabbing, but again, it doesn't have to be either. Some really bad sweating and shortness of breath during the time. Actually, many people can actually have discomfort in their arm and the back, sort of radiating pain from the front to the back in their jaw, like a jaw ache or a toothache. And some people can feel very nauseated, and some people can just feel short of breath. People who have diabetes can have atypical symptoms of just some shortness of breath and not even know that they're having a heart attack. So those are the more, the signs that I think people should watch for. But my, key for people is if you feel like something's completely off and you're not sure what, no matter what symptoms you're having here, go seek emergency help just to make sure that you're okay.
Absolutely. Absolutely. Thank you, Dr. Eccles, for that. My next question is to Dr. Keocha Bond. Is the use of hormone therapy without clinical supervision a common occurrence?
Yes, unfortunately, it really is a common occurrence. And I just want you to understand that many transgender people have a trouble finding a job because of underemployment and discrimination. And nearly a third live in poverty now in the United States. So with that, many don't have health insurance, and those who may have a plan that it may not cover hormone therapy. And so with that in play, like with testosterone and estrogen, that may only cost about $5 to $30 in some cases a month for a patient with an insurance plan, is typically less than $100 per month for uninsured. But if you don't have steady income, that becomes an issue, that becomes a problem. And then on top of that, there are not that many physicians who are trained in gender affirmative care. And this is not something, and I speak of this, it's coming from a medical institution. This is not something that is usually highlighted or in our healthcare trainings for physicians. And so I think this is an important opportunity to talk about that, how important it is to include sexuality and sexual health within the medical training. But even with that, so even when transgender individuals have money, finding a doctor willing to treat them can prove to be very impossible for them. And trans individuals are usually also likely to have bad experiences in the healthcare setting and want to avoid it altogether. And so with that, without access to quality healthcare, they are going to really rely on seeking hormones from friends and through illegal online markets. And even when the cost exceeds what it would with insurance, because they had those negative experiences within the healthcare setting. So I think that is something that we really do need to think about. It's like people are making decisions based off of their experiences and the environments that we're creating for them. So it's not as if they're just only seeking out this because they don't have money. There are multiple factors in play when someone is seeking out medical services outside of the healthcare setting.
Thank you so much, Dr. Bond. And then my next set of questions is to Dr. Levine. Hi, Dr. Levine. Is this something commonly seen in the youth as well who are transitioning using gender affirming therapy?
Well, first, I have to acknowledge two former students on this panel, Dr. Eccles and Dr. Ivey. But to answer your question, we really have two sets of transgender adolescents. One whose parents are on board with what they're feeling, their parents are affirming their identity and accepting who they are. Those teenagers usually do fine. The issue for them is often finding good gender care. The gender care movement in the States is rapidly increasing. But the issue is it does tend to just be in major cities. So when we talk about what's going on in the rest of Georgia outside of Atlanta and Macon, we really wonder what's going on for those families that are affirming in terms of access to care. But we also, especially in Atlanta, have a huge number of thrown away or runaway adolescent transgender, especially women that are on the street, and they're on the street every night, and they are obtaining the same supplies that Dr. Bond was just talking about in terms of street stuff, in terms of sharing stuff. Again, it's not as big of an issue in terms of throwaway transgender men. But for those, again, we very much are concerned about sharing needles as well in terms of an increased risk factor for HIV.
Given that we know tobacco use, alcohol consumption, obesity, these have a higher prevalence in transgender adults. Are these incidents also seen in our transgender adolescents?
Anecdotally, people that do gender care say yes, but as really our first speaker talked about, is the fact that we don't have enough data. So we really the process of trying to get information on transgender adolescents from transgender adolescents is pretty well impossible with especially what's going on, discrimination by the Republican Party specifically, damaging activities that are being done to our transgender youth.
In caring for these patients, what conditions or concerns would prompt you to consult a pediatric cardiologist?
Yeah, what can you say? When you're a gender care provider, you develop, I think, a stronger bond with them than other patients. And so we do tend to have more of an impact because one of the first things that we do is listen to them and accept them and want to partner with them to improve their health care.
Right.
But there are, people, especially that might be interested in starting on estrogen, that I certainly would be worried about pre-existing cardiovascular disease. So in those patients, if they're presenting with hypertension, if they have obesity with hyperlipidemia, of course, if they're an adolescent, any adolescent that presents with a new heart murmur, also if they're developing any symptoms of syncope or palpitations, those to me are going to trigger an urgent referral to pediatric cardiology.
I see. Dr. Ansong, would you like to weigh in on this?
Yes, thank you. Thank you, Dr. Levine. And I completely agree with what he said as far as when to refer to pediatric cardiology. I think first and foremost with Marcus is that we have an adult with these cardiovascular risk factors. So it's important early on, during his childhood, that these risk factors be identified if present by the pediatrician. And if so, then having a really targeted approach between Marcus and his parents and trying to mitigate these risk factors so that he doesn't become an adult with the issues that he has now, because we really want to take care of it from the beginning so that we don't see what we're seeing now. Thank you.
Thank you. All right, now we're going to go ahead and finish Marcus's story. I'll give it back over to Dr. Ivey.
So with all that's going on with Marcus, he is eager to establish care with a clinician, and he begins to prepare for his appointment. Marcus begins to search online for LGBTQ plus friendly doctors, but these practices are either located too far off the bus route or have no availability for the next several months. So instead, he chooses another doctor's office that's just located close to his house, hoping for the best. Before the appointment and after proactively sending in his paperwork, he's disheartened when reading the emails and text messages confirming his appointment. They each misaddress him. He attempts to correct this over the phone with the clerk, but noticed that even she ended the call by calling him Monica, his dead name. Already frustrated and nervous, he considers canceling the appointment altogether, but decides to go anyways, motivated by the thought of his girlfriend and children. So in the waiting room and during check-in, Marcus notices that the receptionist was very short with her responses and would barely engage when he tried to make small talk. While she did attempt to ask if he had any questions, he noticed she seemed uncomfortable and avoided making eye contact with him, yet she was very friendly to the other patients. Upon reviewing his paperwork, he noticed that there was nowhere for him to fill in his pronouns, if he and him. Thus, he filled them out and up at the top in parentheses. He looked around to find any indicator that this might be an LGBT-friendly clinic, such as like a pride flag, but found none. So we know a medical LGBT ally is well-versed in the correct language to describe their patient's sexuality. They do not automatically assume that the patient is straight. They don't say or do offensive things, and if they do, they correct themselves and apologize very quickly. These people are committed to understanding how patient sexuality and gender identities may influence their health, and they generally treat all patients with respect, no matter what. So this next question is going to be directed towards Lisa Cunningham. Marcus was originally misgendered in the clinic, as you just saw, by the medical assistant. How can the patient and healthcare professional best correct this in real life?
Well, thank you for that question. And I think it goes first and foremost to something that I think it was Dr. Bond who may have spoke on earlier. I mean, we've got to totally discuss the training on the early part of the education. And that will mitigate some of this. The organization that I work with, one of them, the Black Women's Health Imperative, we actually created a guide, an affirmative care for Black women of transgender experience. And this is a pretty robust guide, over almost 40 pages of information. But in that particular case, one of the things that the guide brings out is creating medical forms that collect information on assigned sex and gender separately, making sure you put the word assigned before sex on the form, allowing people to openly identify their gender without limiting the selection of choices to male or female. Once again, what Marcus was going through. Also, the very first thing would be that there needed to be some training there with that receptionist, right? So we need the trainings on implicit bias and cultural humility. Also, certain things that people may not think of that affect people like myself. I'm not even a person of a transgender experience, but I experience certain things because I do present more masculine. And so things like neutralizing the bathrooms would help as well. And then you mentioned this, the visual representation, having posters, flyers, brochures, and magazines in the waiting room that have diverse photos representing women of a trans experience and addressing health issues that are important to that community. So those are just, I'm literally giving you a quick snapshot of some of the things in this guide. I'll put it in the chat. Anyone can download this. And quite frankly, it's just a wonderful resource, not just for, clinicians, but just for all of us to get, a bit of some knowledge on this community and how we can all be allies.
Thank you so much for that. And I know you have a couple of different resources out there for people if they want to hear more about your story, between the podcasts and podcast interviews and the TED Talk. So I know that, I just want to give that plug out there that even though we don't have time to necessarily go into all those stories right now, they are out there and they're really powerful. So thank you for sharing your story. Thank you. So at this point, Dr. Webb, would you like to take us back to the clinic with Marcus?
Yes, absolutely. Thank you, Dr. Ivey. So when it was time to be escorted back, the medical assistant called Monica Boyd, but then she appeared clearly confused upon seeing Marcus's facial hair. He corrected her at the door, stating he goes by Marcus and that Monica is his dead name. The MA became visibly embarrassed and apologized, explaining how the information sheet she received auto-populates the name on the insurance card. She then offered to have the name corrected in the chart. Now, the rest of the triage went well, and the MA apologized again for the mistake. Marcus's triage vitals, however, showed a normal temperature, a normal heart rate at 86 beats per minute, but a very significant elevated blood pressure at 164/96. His BMI was also significant at 38.4 with normal respiratory rate and normal oxygen. Okay. So the exam, when the doctor, who is a cisgender male, walks into the room, he addresses Marcus with the appropriate pronouns. Now, this allows Marcus to let out a sigh of relief. Marcus begins to explain his past medical history. But once they get to his reproductive health, Marcus notices that the doctor seems slightly uncomfortable with asking about his past pregnancies. Marcus takes it upon himself to describe his 2 previous pregnancies and complications. Marcus tells the doctor that he is currently on testosterone replacement therapy inconsistently, which he is buying from the street, and that he is in a monogamous relationship with his girlfriend of 6 years. Thereafter, the remainder of the visit, to Marcus's confusion, the focus was on his sexual history. The appointment ends with the doctor telling Marcus to stop by the lab before leaving to get a series of blood tests. Additionally, he briefly comments on his high blood pressure. He counsels Marcus to avoid salty food, promising to be, skipped a bit of the presentation. I apologize. I actually wanted to ask a question prior to going to this. So before I do the rest of the exam, let me just go back. I apologize for that. So although LGBTQ individuals face increased risk for HIV and STIs, best documented for cis male having sex with other males, with rates of HIV, syphilis, and gonorrhea exceeding that of the general population. The infection rates of transmasculine and non-binary folks remain unknown, highlighting the need, of course, for more dedicated research. Beyond this, addressing general health concerns with STD screenings is important, but many a times challenging, as promiscuity stereotype may derail a provider to focus only on sexual health, as we see here, and miss opportunities to discuss active symptoms, such as indigestion, which we know Marcus has been experiencing. Dr. Keocha Bond, how should providers best ask for sexual and reproductive history without losing sight of the other aspects of the medical history that are equally as important?
One, I think in general, when we are talking about sexual health, we do need to create that welcoming clinical environment at the registration part, and also be more inclusive, gender inclusive when we're talking about sexual health. In this case, that wasn't the primary reason why Marcus was coming in, and the provider ignored their symptoms and really disengaged them. But when we are talking about sexual health, there are, like, I call them the 6 Ps. We're talking about sexual health, which is asking about pronouns, asking about partners, what are the genders of your partners, how many partners in the last 3 months, parts. And when I say that, is like, what words do you prefer to use for your body parts? Have it as a dialogue with the patient. So it's not as if you're inflicting your own implicit bias in the room, basically, and you're allowing the patients to tell you what are the proper words to use with them. And so also talk about protection. How do you protect yourself against HIV and other STIs, and ask about their past history of STIs and what was it, where was it, and how was it treated. But in any case, when you're in the room with a patient, you should acknowledge the patient's need. You should put them first, and separate your own, again, implicit bias in the room, because what happens is that the patient in itself, in that situation, is going to feel judged, and they're not going to be willing to be more open and talk to you about what they're experiencing. And they might not want to come back because of that. And again, that becomes another barrier to healthcare.
Exactly. All right, I'm going to go ahead and let Dr. Ivey finish Marcus's appointment here. Sorry about that jump.
No, it's fine. So the appointment with the doctor ends with the doctor telling Marcus to just stop by the lab, get his lab work done. However, before that, he very briefly, comments on his high blood pressure. He counsels Marcus to avoid salty food, promising to recheck his blood pressure at their next visit to determine if a prescribed medication will be necessary. Unfortunately, this was all done in a rush because time was up and they had no time to discuss the remaining history or to address Marcus's concerns of indigestion. Consequently, Marcus leaves without making a follow-up appointment or completing the lab work because he was just kind of over it. So as a healthcare practitioner, unfortunately, it's uncommon to receive formal education regarding LGBTQ healthcare, thus providing culturally competent and appropriate medical care to these patient populations in hopes of reducing these healthcare disparities is very challenging. To date, there are 0 requirements in either medical schools or residency or fellowship trainee programs that include formal education on these issues. Dr. Eccles, I have a question. What could have gone better with this first meeting between the doctor and Marcus? After all, Marcus still has risk factors between his family, his obstetric history, this indigestion that are concerning. What things could the doctor have done differently in terms of diagnostic testing at the time of this initial meeting? What do you think?
So great question. I think number one, slow down and treat Marcus as you would any other human being that is coming into your clinic. You know, as a physician, you cannot be thrown off by things that you don't expect or things that you find out about patients, because when you do that, you instill distrust. And let me, you know, again, as a member of of the LGBTQ community, I know that the energy that people can give off when they're uncomfortable with you or when they're distressed or feeling, you know, some kind of way, particularly in the African American community as well. But you can slow down and you can sort of reset yourself and make sure that you do everything in a systematic fashion. And you know, anything that you would ask any normal new patient, you ask this of Mr. Boyd. And so it seems simple, but when you get flustered and busted because you're thinking about all kinds of other stuff, that doesn't serve the patient. So if you have to, reset yourself, however you may need to do that, you need to make sure that you're treating this person as a human being like you would anybody else.
Right. So in as I think about it, even as a doctor myself, maybe I wouldn't have gotten an EKG this particular time, especially I don't know anything about the indigestion because we didn't get to it. But, even with how quickly the blood pressure was addressed, can you kind of talk to us about, high blood pressure and what providers can do for a patient in these types of situations?
Well, I mean, I think that, so to your point with the EKG, again, I think that anybody with cardiac risk factors such as this, in a sort of guideline-based approach, you would warrant actually getting an EKG for this person to at least give them some indication of what, if they have any structural heart disease that you can see that's asymptomatic at this point. But again, blood pressure. So these are the guidelines for blood pressure control. And as you may know, over time, these numbers have actually dropped further and further because we know the higher your blood pressure gets, or the top number gets over 120, there's more increased risk for cardiovascular disease down the line, or stroke. Same thing with diastolic blood pressure. But, these are the levels that we now classify blood pressure as. So if you have a blood pressure of less than 120 on top and less than 80, then it's considered normal. However, elevated now is considered to be between 120 and 129 on the top, with less than 80 on the bottom. And then stage 1 is considered now with the top number being 130 to 139, or this is important, or the bottom number being 80 to 89. And then we have this, we basically have 2 stages. So stage 1, stage 2 blood pressure, or high blood pressure. And that's basically stage 2 is anything greater than 140 over 90. And so I don't know, well, Kendra, you're still probably really young, but normal blood pressure used to be like less than 140 over 90 a long time ago. And so I think that this is important to know how we've sort of shifted down in order to prevent cardiovascular issues long term. Then, of course, the hypertensive crisis is higher than 180 or on the top, or anything higher than 120 on the bottom. And that's some vicious blood pressure. That person needs to be, ushering themselves to some urgent or emergent care rather quickly.
That's right.
You also, the last thing is, you also have to be a clinician and understand the process by which you're getting this blood pressure. So you need to make sure that the blood pressure is being done properly. The patients are not slapped on, sat down in the chair and slapped the wrist, cup is slapped on as soon as they get there. It needs to be, taken in the way the guidelines suggest. And you also have to understand some people, whenever they're running late, or whenever they are sitting for a long wait, or get offended like Mr. Boyd, blood pressure will go up. So you have to be able to know how to manage that with lifestyle intervention, as well as continual management, to your understanding more how to treat the situation.
And home blood pressure monitoring, can't beat it.
Exactly.
So, all righty. Thank you so much, Dr. Eccles. So, Dr. Webb, right now, can you kind of transport us into the most recent development in Marcus's case?
Absolutely. So let's look at Marcus's story 3 months later. So the same doctor is covering the hospital inpatient service and sees Marcus Boyd, who presented with severe heartburn and was subsequently admitted with a heart attack. EKG on admission was significant for a massive heart attack. He was emergently taken to the cath lab, which revealed 100% blocked artery in one of the major arteries of his heart, also known as the widowmaker, and then 2 stents were placed. On review of Marcus's chart, he finds that he had an A1C of 9.5, which is significant for diabetes, uncontrolled diabetes, a lipid panel, which we use to monitor cholesterol levels, that was pretty significant, an LDL of 194, which is really high. And his blood pressure on admission was severely high at 176 over 102. When entering Mr. Boyd's room, he immediately sees the disapproval on his face. Unsure how to address the tension, the doctor just decides to ignore discussing the appointment, performs a thorough exam, and updates the patient on the plan. Marcus requests to see another provider, but the doctor explains that he's only on for the day and the usual provider will be back on tomorrow. The doctor completes the assessment, writes his note, signs out to the night covering provider, and says nothing else regarding this encounter. Now, Dr. Eccles, seeing Marcus's laboratory numbers and understanding his initial symptoms, like we discussed, are you surprised with this outcome of a massive heart attack?
No.
I know you're going to say.
No, but again, I'm not sure if anybody else would address this, but I'm also speaking from the physician standpoint. This is, again, an opportunity for the physician to swallow pride, swallow ego, and establish a trusting relationship with this patient, because that is not the way you handle a patient the second time you're seeing them, in the hospital. But to your point, so in terms of understanding the CB risk factors for the disease stats with hormone therapy, is that what you're getting ready to ask me? Oops, sorry.
Let's just go. Let me just go to the next slide.
Okay. Doing your job and mine. No. But no, the initial symptoms are not surprising at all. His labs, unfortunately, this is what we see all way too often. The actual surprising thing is, to be honest with you, is that he made it to the hospital, because one of the first symptoms of cardiovascular disease or acute coronary syndrome, 50% of people have sudden cardiac death. So he has a 1 in 2 chance of actually dying before he gets to the hospital. So that's the amazing thing, that he got to the hospital, thank God. But in terms of gender, affirming therapies with cardiovascular impact, I think it's very important for us to understand that transgender men actually have a greater 2 times higher rate of heart attacks compared to cisgender men, and 4 times higher rates than cisgender women. The use of gender affirming hormone therapy in transgender populations has actually been shown to increase risk factors for cardiovascular disease, but we know that is based on past data, and some of that is related to the procoagulant effects that some of these gender affirming hormone therapies can cause in patients, as well as combined with their risk factors of smoking and things of that nature and family history. We do know that gender-affirming hormone therapy in transgender men has also been associated with the potential of elevated blood pressure, insulin resistance, and cholesterol abnormalities, and with an increased risk for blood clots, as I just said, and heart attacks for transgender women.
Yeah, absolutely. Thank you. So what should the physician have counseled Marcus on during his initial meeting, and most importantly now?
So I think, in general, are we going to the next slide? There are pretty much, sorry. So ABC endorses these 7 steps for a healthy heart. And again, these things seem so simple, but it's so hard to get people to do. But I think if we just kind of take 1 step at a time and try to sort of reach these goals on sort of day to day, it becomes easier for people. But you should get access to better health care. And that even means if you are with a physician or a provider that you're not connecting with, or you feel like is not listening to you, you have my permission to go somewhere else. I think it's important for you to have a very good trusting relationship with your provider. You need to take charge of your blood pressure. And that means recording the numbers, looking at them, evaluating your diet, making sure that whenever you associate higher numbers with something that you probably shouldn't have eaten, to try to sort of lessen that or decrease, the intake of that. Control your cholesterol. A lot of people think that cholesterol sometimes is all related to what we eat, but it's not really. Sometimes there's family history and familial issues there that are out of our control. And no matter how much you fix your diet and exercise, sometimes in order to reduce your risk of heart disease, you're going to have some other management sometimes. Track your blood pressure. Again, I'm sorry, blood sugar. This is incredibly important. Diabetes runs rampant in our community. Don't use tobacco or nicotine products or alcohol or any of that stuff, because that also increases the risk for issues. And eat smart and enjoy regular exercise. This gets to the fact of just trying to kind of not be physically inactive. And there are many, many ways that technology now has made us less inclined to do anything. And so sometimes it's a struggle to get out of bed at 6 o'clock in the morning. But it's what you want for your health, for the greater good. And then last but not least, being spiritually active and reducing your stress. Now, again, spiritually can be taken in a number of different ways, but being spiritually active and spiritually healthy is just as important as being mentally healthy and physically healthy. So it's sort of a triad here that you're trying to seek in terms of reaching ultimate wellness.
Absolutely. I agree. Thank you, Dr. Eccles. Dr. Keocha Bond, what could have gone better with the subsequent meeting?
Really, I think the main thing that could have gone better is if the provider listened. And one of the things that usually doesn't happen in these cases is that there isn't that exchange, and the providers are not doing the work that they need to do to make sure that their patients are feeling comfortable in these settings, and they are not checking themselves at the door. One of the things that in my research that I came up, and when I do research with transgender women, is the fact that many of them feel like they're living, and I live in New York City, and so we have the different boroughs to kind of explain to other people. So I live all the way uptown in the Bronx, and a lot of the research that I do is focused in the Bronx area, and many of them will travel over an hour over on the train to go to providers who they feel that they will have a good experience with, that they will not be discriminated by, they won't feel slighted, they will be heard, they will be seen. And so I feel like that was the thing, that was a missed opportunity for the provider to do the homework and do the work that's necessary so that they can provide adequate care to anyone that comes into their healthcare setting. And so that's really what kind of stood out to me in this whole story about Marcus, is that some of the health outcomes could have been prevented if the provider had done the job. And I always take responsibility as being part of an educating institution. If we do the job also and advocate for this, as you said, there's no requirements really for gender affirmative care, sexual health care in medical and health profession settings. And so we need to do more work with this.
Absolutely. Absolutely. Lisa, what could the healthcare team do to make Marcus feel comfortable and have a positive visit to ensure follow-up?
Well, I mean, so much has been stated already. I mean, I just hearing Marcus's story, even though I'm not trans, I remember getting ready for surgeries. And I mean, this is very recent, and not having, basically I had told my primary care physician that I was not taking my high blood pressure medicine, right? And I said it kind of quick, but I was about to have a surgery. I was still, my BMI at that time was probably 41. And he didn't even pay any attention to me. So I had not been taking it for a while, finally got back on it later after my sister, who is a pharmacologist, I cavalierly told her one day, as I had lost all of this weight recently. And I said, yeah, I haven't been taking my blood pressure medicine in a while. And she said, you had the surgeries? your doctors didn't tell you? What are you talking about? She goes, I don't care if you get down to a size 6, you will take that medicine from now on. And it just was so alarming for me that I didn't get that from my, healthcare provider. So one of those things is just to listen to us and don't brush us off. I don't know if it's, the exterior, and it's just like, but you can't have that bias that I'm okay,
Right.
because I look and present a certain way. It was, and I just think it's just, slowing down a bit. I heard that, a couple of times today as well. So, I think so much has been already stated as to how we can, mitigate this in the future. But that training is going to eventually be the crucial key here.
Absolutely. Dr. Levine, how will this heart event impact the ongoing use of Marcus's gender affirming therapy?
Yeah, so obviously estrogen is the big issue right now, because obviously with estrogen, you already have 5 times the risk, 5 times the risk of a thromboembolic event.
Right.
So if I'd actually had somebody who'd had this issue, I would have, definitely consulted a cardiologist. In the meantime, we could still use other medications such as spironolactone, not a bad, mild antihypertensive, but that will at least block testosterone effects, so that you can start having some transition. For testosterone, really the only thing that we worry about is increased blood pressure. I did see on the other slide there are other risks that have been reported. And so we look for that. So once a year for people on testosterone therapy, I am checking a cholesterol panel. But I think, again, it gets back to that first initial statement. We don't have enough data.
Right. Right. Yeah. All right. Thank you all for answering those questions. I'm going to take it back over to Dr. Ivey as we conclude Marcus's story.
Thanks so much. So we're still in the hospital with Marcus, and coincidentally, he receives a phone call from one of those LGBT doctors that he found online during his Google search. He didn't realize it, but he had in fact requested an appointment, and they were calling to tell him that one was available. On discharge, he finally gets to meet with this physician, and that provider then refers him to an allied cardiologist and an endocrinologist as well. And I think that this perfectly addresses the last question that we had with Brent, and asking, how can we know what providers are either allied or of the community themselves? And it can be really challenging. So for Marcus, luckily, he, did get in to see one of those doctors, but by that, he was then able to find 2 other doctors who were allies. And so word of mouth is important. The Google searches and databases online, sometimes they're not up to date. You just have to keep trying. And the thing that I think is most important is making sure that if you find someone, even if they have no availability for the next 3 months, just go ahead and book it. Because Marcus did it on accident. But just go ahead and book it, wait the time. And if you have something more pressing that you need to be seen about right now, go be seen about that. But then you still have the other doctor on standby. So can't lose. So now the best part about this story is, after all of this, after finding providers that are good for Marcus and that he really respects and appreciates, and who respect him mutually, he is now dedicated to living a heart healthy life. Now he's serving as a role model and teaching healthy habits to both his children and his girlfriend, and all for the goal of ensuring generational health, which is what we need for our families. So the take-home points that I'd like to talk to you all about are these. And I'll start with the quote. And these are take-home points for clinicians and providers. So no pride for some of us without liberation for all of us. And this is from Marsha P. Johnson. She was an activist and prominent figure in the Stonewall Uprising in '69. So for people who are treating this patient population, these are the things that we have to be more aware of. 1, accept that we all have unconscious bias because of the society that we've grown up in. 2, seek out resources to mitigate and fix this unconscious bias. It can be done. 3, create a welcoming environment the way we have already discussed. Pride flags, giving an option for pronouns on paperwork, like that's so meaningful to people. Wearing pride attire, whether it's a lapel pin or I have a rainbow stickers all over my badge, and these things matter. If you don't understand something, providers, ask, okay? Just ask, it's okay. Familiarize yourself with the unique barriers experienced by LGBTQ people. Focus on treating the whole person and not just their sexual identity, which is unfortunately what happened with Marcus. And take home points for Dr. Webb.
Yes. So these are for our LGBTQ plus patient community. Feel empowered, okay? If a provider makes you feel uncomfortable, you can address it, or you can ask for another provider. You are not obligated to stay in an uncomfortable environment. You're not obligated to take on disrespect, and you're definitely not obligated to be ignored. With that being said, give people the benefit of the doubt. As Dr. Ivey mentioned, sometimes as providers, we don't know. And while we ask, it will help if you help to explain. No, I'm not saying it's your responsibility to educate everyone, but don't assume people don't want to understand you better. If your primary concern was not addressed during an appointment, and I can't stress this enough, please speak up and tell the provider. Something like Marcus telling the provider he initially seen about the heartburn and really pressing that issue could have probably saved him from having a massive heart attack. Also, there are many organizations working for you. Resources and support are available. So let's take a look. All right. So there are efforts underway led by the U.S. Department of Health and Human Services, including CDC and the Health Resources and Service Administration, to collect data on the LGBTQ plus populations to increase the amount of data needed to inform further research, healthcare providers, advocates, and policymakers to identify and address health disparities in this population. In 2015, the Office of Sexual and Gender Minority Research Office was established within the National Institutes of Health. Healthy People 2020, now called 2030, outlined an objective to improve the health, safety, and well-being of the LGBTQ individuals. More medical school and residency training programs are integrating LGBTQ healthcare into curriculums in hopes of destigmatizing beliefs. However, formal training has not been mandated as of yet by the AAMC or ACGME. And of course, there are other organizations indicated here that are also working towards improving health and safety for our well-being of our LGBTQ individuals, including ABC, as we have discussed, and as well as Dr. Keocha Bond Love Project Lab.
So at this point, I just wanted to say to our panelists, if there are any final remarks or anything that you didn't have an opportunity to share with everyone that you'd like to share, let's do that now. So we can start with Lisa Cunningham.
Hi, yes. I didn't mention one thing, and it's that I think a lot of us as Black Americans grew up with this notion that the doctor was the only person who kind of had the task of, taking care of our health. And I just want us to all continue to think about this journey as this partnership between the physician and, you know, you as the patient. And I think that that's something that I've most certainly learned, and I will spread that gospel wherever I go.
Thank you. Dr. Keocha Bond?
Yes, I think it's one of the things I really wanted to highlight also is that unfortunately with COVID, we had to go through a lot of different changes and learning how to communicate differently. Like we're doing the Zoom talk now, but that also allows us to have more access to different people and more access to people and providers and healthcare access. And so I think that's something for us to think about when we're looking at some of the disparities associated with engaging in care, that with telehealth, with the more with information that's available on the internet, that from reputable sources, we do have people have opportunities to learn more and to increase their health literacy and engage in good healthcare, I think so.
And Dr. Bond, I just want to briefly say, can you just give us a quick summary of what you and your team are doing and the incredible work that you all are doing at CUNY?
Oh, wow.
Just really quick. In your love project. It's good stuff.
Yeah, we're doing a lot of great work. Our work is focused primarily I think we're working with everybody, but it, you know, encompasses Black, gay, and bisexual and same gender loving men, transgender women, gender diverse youth, but mainly it's focusing on addressing the stigma that's associated with HIV, that's associated with just being Black, with being queer, with being a woman, however you may identify in our society, and trying to address this within our community and really taking a more positive look on it and looking at the tool, I always say the gifts that we have and not looking at what we don't have and looking at what's positive about our lives and kind of building upon that. And so our work it's a lot. We're getting there. We're doing some great things and we're fortunate to be able to work with great community members and to continue to do this. And our students are involved at the CUNY School of Medicine, which I'm always very excited about. I love teaching them. I always teach them their first year. And I'm about to, in 2 years, I'm gonna see my first student graduate with her MD. So I'm just excited about that happening because they really are trained in cultural not just cultural competence, but cultural proficiency. And that's part of the whole 7 years that they're there. And we're training these physicians to do the work. And that's why my great cousin, Rachel Bond, is doing this work right now because she's a part of that program. So I just want to give the school that credit also.
Yes, thank you so much. We really do love the work that y'all are doing. It's incredible.
Absolutely.
Dr. Levine, is there anything that you would like to add?
Just, a couple of things that to me are exciting on the transgender front. Morehouse is trying to build a comprehensive transgender center. I see patients, but we definitely want to integrate a multidisciplinary team. And we have the players. Now we're just at the point that we're pursuing funding and institutional advancement from the school has actually been quite helpful. So we have proposals to a bunch of donors that are around, and it's amazing when you start researching how many wealthy transgender people there really are, because there are a lot. And then just not to leave people feeling gloom and doom related to what's going on in legislatures. We have very active, very empowered law organizations that are already fighting. And if the injunction's not there already, it shortly will be in Alabama and Texas that prohibited transgender care. Those are the only two places that have approached it. In Georgia, there was a bill, but it was killed in committee because it would have destroyed the economy of Georgia because so much of it now is based on arts and entertainment. So it's interesting that even the conservatives are still playing the numbers game. So again, we have an opportunity to improve transgender health, not just re-entrench because of these restrictive laws. and we're really excited about it. Telehealth is such an amazing opportunity for us, because what physical exam do I really need to do once I start hormone therapy? Am I curious about what organs are growing? I can ask the patient to tell me. They don't need to show me. And so, we can do the visit by telehealth. They can go to their local lab. I get the results. And that's what we're also looking to do to reach the rest of Georgia as well.
Thank you. Dr. Levine, I have genuinely, since medical school, always admired the work that you've been doing for this population. And I just wanted to say thank you, and for your persistence and all those warm, fuzzy things. Thank you. Dr. Eccles, do you have any final remarks, anything that you'd like to share with us that you haven't already been able to share?
I am so grateful that the Association of Black Cardiologists has use this platform to talk about such important issues. I think we need to really continue to address, and this is something our people need to really think about, address the intra-group implicit biases that we have for one another. We are not separate entities, gay, Black, white, we're intersectionality is so great. And so as in the African-American community, we need to continue to address those implicit biases that we grew up with that cause us not to be who we are, or cause us to have the stress and the psychosocial stressors that lead to, worse outcomes. And so this is one of the greatest steps that we can do on this platform. And I just employ people, whether you're an ally or a part of the community, continue to address those intra-group implicit biases.
Thank you so much. I'm really proud of the ABC for putting this on today. I'm grateful for it. So at this time, I will hand over the mic to Dr. Bond and Dr. Ansong to close us out. I'll just personally say thank you, everyone, for being here tonight. I've had a really fun time. Thank you.
Absolutely. Thank you.
Yes, thank you. And thank you again to our esteemed panelists, as well as our moderators. You both did a phenomenal job, Dr. Ivey, as well as Dr. Webb. I also want to, of course, thank my co-chair, Annette Ansong, Ms. Rachel Williams, who's our ABC staff support, Mr. Alan Merritt, our ABC IT expert, Dr. Anwanye, who's the ABC president, and all of the leadership at ABC for creating such an inclusive environment that truly does support a webinar with such a fund of knowledge and insight. I know I definitely learned a lot today, and I hope all those on the call also have learned as well. And we know that having such an environment doesn't just take care of our LGBTQ plus community, but it actually takes care of all of us. And we really need to focus on that inclusivity. So for my closing remarks, I really want to just very briefly, if you could advance the slide forward, go through a lot of the key things that we at the ABC are doing in terms of our partnership and who really supported this webinar and hopefully future webinars like this. So we'd love to give thanks to the Black Mamas Matter Alliance, Black Health Matters, Human Rights Campaign, PFLAG, Women Heart, as well as blackdoctor.org for really helping us to get the messaging out on such an important webinar. Thank you. These are resources for clinicians that I do think are very helpful. One being best practice in North America, preclinical medical education and sexual history taking, others being the American College of Cardiology, really talking about how to transform care for the LGBTQ community, as well as the Endocrinology Society guidelines on how to best treat transsexual people, the American Heart Association 2020 scientific statement that really talks about how to assess and address cardiovascular health in the LGBTQ plus adults, as well as tips on LGBT terminology. We gave you kind of the alphabet soup as Dr. Keocha Bond really walked us through, but these are just key resources for you as clinicians. Now, for those patients or those in the community that have interest in learning more, either be it that they're in youth or adulthood, the CDC has phenomenal, really great resources that I would recommend each and every one of you reach out to or look into. I also want to acknowledge that the ABC has partnered and created a coalition of members for several initiatives to address uncontrolled blood pressure, something that we talked about, which Marcus clearly needed a better insight into, and that's really the responsibility of the clinician. But a lot of our initiatives have been centered on two campaigns, one being Release the Pressure campaign, which is releasethepressure.org, as well as livetothebeat.org. And to learn more, I do really recommend that each and every one of you go to their website. In addition, the ABC Women and Children's Committee, which I'm so fortunate to co-chair with Dr. Annette Ansong in February, helped the ABC launch an initiative to address the Black maternal mortality crisis. As we know, women and birthing people are dying of higher and higher rates when it comes to maternal mortality, and it is impacting the Black community most notably. Why this is important is Marcus, as we highlighted, did have a complication during his pregnancy, which was preeclampsia, and that's a very common cause, as I mentioned, of poor outcomes. So with this campaign, we're really trying to drive the message to ensure that you understand the signs and symptoms to look out for, you understand the risks, and more importantly, you understand the importance of having that follow-up with your clinician. So for anyone interested, please feel free to join us at wearethefaces.abcardio.org. We do have some upcoming events that I do want to let those out in the audience know. We have a wonderful advocacy committee through the Association of Black Cardiologists. And on Monday, June 20th, we will be having a webinar as well at 7 p.m. Eastern. If you are interested, you could register at abcardio.org or via the link below. And lastly, as mentioned throughout I think the theme of this webinar was that we really are so appreciative of ABC taking the time during Pride Month to give such a phenomenal talk that's really geared towards the most marginalized groups. And we hope that for those that may not have a membership with ABC, you'll consider a membership, or those who want to really help support the actual work will also consider doing so by going to abcardio.org. And thank you all very much. I will give you back your time, and I do appreciate you giving us an extra 15 minutes of our time, and I hope you have a wonderful night. Bye-bye.